Good evening, everyone, all my seniors and dear colleagues. Today, our topic of discussion is cervical cancer, the changing perspectives and the nuances. We all know that cervical cancer is associated with high maternal mortality as well as morbidity, but this is a preventable cancer and it should not be happening so. To discuss all this, we have gathered today and we have all the stalwarts of oncology uh, for whom we have held this stage. I would like to invite Dr. Sunita Malik ma'am to offer a formal welcome to all of them as well as the audience and our students. Dr. Sunita Malik ma'am is a professor and senior consultant at VMMC Medical College and Safdarjung Hospital. She is unit head there. And she is also the uh, chairperson of the Oncology Committee AOGD. And she is the brain behind all the CMEs which are being held in oncology every month, and they are of great use to all the clinicians, practitioners, as well as the students. Dr. Sunita ma'am, please welcome. We offer a warm and formal welcome to all the faculty and audience.
Thank you, Dr. Poonam. So to start with, welcome to everybody who have joined, made an effort on the pre-Diwali weekend for this particular webinar. And so we know that it is a preventable disease because it is a long pre-invasive phase, and we have screening tests available, and we have treatment also available for the pre-invasive region. But unfortunately, in spite of being the preventable nature of the disease, according to Globocon 2020, everybody knows that worldwide about 6 lakh new cases are added with 342,000 deaths worldwide. And of this, India contributes to 1,23,000 new cases, Indian subcontinent, with 77,000 deaths. But nevertheless, the worldwide incidence of invasive cancer is decreasing, and cervical cancer is being diagnosed earlier, leading to better survival rate. The initiating event we know is cervical dysplasia and carcinogenesis is because of infection with HPV. So many newer tests have been introduced in the last 15 years, be it we advanced via based on AI machine learning platforms, molecular tests based on HPV DNA, mRNA, oncoproteins, and methylation, then P16 and Ki67 cytology samples genes were being stained. Similarly, in the management of invasive cancers, we have a better classification of cervical cancer, which we are going to discuss today, which has included the radiological and pathological staging also in between. And we have better advances in chemoradiation techniques also, with better quality of life. Earlier, those who used to get radiotherapy and then the horrible quality of life used to be there. Then, of course, although debatable, MIS is also there in cervical cancer. So Dr. Urvashi and Dr. Poonam, they have chosen these topics for today, CME, based on cervical cancer, what are the nuances and the changing perspectives. So I welcome you all to this webinar. We have got a very eminent faculty for discussion. Thank you, and let's over to Dr. Poonam.
Thank you, ma'am. Thank you for your inspiring words. Now, I would like to invite our AOGD president, none other than Dr. Achla Batra, a very kind-hearted, warm, inspiring, and encouraging teacher. She is a leader with a vision. We would rather love to hear from you, ma'am. Please, Dr. Achla, ma'am. Ma'am, you are muted. You are muted, ma'am.
Thank you very much for the kind words, and good evening to all of you, and wishing you all a very, very happy Diwali in advance, because I think this is going to be the last CME before the Diwali. And next month we have a bonanza of AOGD workshops and conference, for which I would like to invite all of you. And I said earlier that on 19th we can all meet physically also. And today's topic is really very nice, because though we have known about CS cervix from, I don't know, the time we have been studying MBBS, but the things have changed from then to now. And I think everybody should be aware of the new changes, the new perspectives, the new methods of screening and new methods of treatment, because still in India we are we not reach very far ahead in CA service. But today also I see patients of CA cervix of advanced stages, even in a very, we're saying in the younger age group now, that is what is happening. And you wouldn't believe, till now I have educated patients telling me that they have pain in their cervical region. So cervical region means the neck. Should they get a pap smear done? And this is the state of affairs of of educated people also. I think we have a large task in front of us to educate all these people and to educate our doctors about the newer things which you are trying to do today. So I think you have stalwarts, you have Amita, Manas, Rupinder, and all of you who are working in this field. And thank you very much for making me part of this, and wishing you a very, very good CME, and which everybody is going to take home very good points. And I once again invite you all to the AOGD conference, in which we have international faculty like Nicolaides for fetal medicine, and Ajay Rana for urogynecology, and Nina Rana from WHO for cervical cancers. They're all going to join us. So a good day to all of you, and happy learning. Thank you.
Thank you, ma'am. Thank you. Now, without wasting much of our time, let's move to the academic session. We would start our academic session has the first, it is a session of 2 talks. And to chair the first session, I would like to invite Dr. Manas Biswas and Dr. Mala Srivastava and Dr. Sunita Malik. Dr. Manas Biswas, as his name suggests, he's a man who can be trusted upon. I met him for the first time during a postgraduate exam in Base Hospital, and I was really impressed with his personality. He's a man with golden heart, an oncosurgeon. Presently, he is working at Max Super Speciality Hospital, Saket, and he is a fellow in oncology from Tata Memorial Hospital. He has headed the Department of Gynae at AFMC and Army College of Medical Sciences, and many laurels to his name. Our next chairperson is Dr. Sunita Malik. Dr. Sunita Malik, ma'am, is a senior consultant, unit head at VMC and Safdarjung Hospital. And she's a chairperson, Gynae Oncology Committee, AOGD.
Told Dr. Poonam, let's go ahead.
Okay. Thank you, ma'am. Thank you. You are the brain behind all the motivation. Our next chairperson is Dr. Mala Srivastava, ma'am. And Dr. Mala Srivastava, as I have interacted with her during the evening classes, I know her personally. She's a gem of a person, our past AOGD present, a very good clinician, very good academician, and she has a heart of golden wax. Heart of gold, she always thinks about others, and wax, it melts very easily in front of students. Welcome you, ma'am. We would like to hear from you. I would like to invite the next speaker, Dr. Seema. I would like to invite her, ma'am.
Thanks, Dr. Poonam, for your kind introduction. First of all, I must congratulate you and Dr. Urvashi, as well as Dr. Sunita Malik, for organizing such a useful conference, useful CME for all of us. It's my pleasure and privilege to invite the first speaker of the day, Dr. Seema Singhal. She's the additional professor, Department of Obs and Gynae, All India Institute of Medical Sciences. She has lots and lots of awards to her credit. She's been editor of and executive committee member of AOGIN, member of AOGD Oncology Committee. We are waiting to hear from you, Dr. Seema, regarding the latest cancer cervix FIGO classification and its implication. Over to you, Dr. Seema, for your scientific deliberation.
Thank you, ma'am. So I'm thankful to Dr. Urvashi and Dr. Poonam and Dr. Malik for giving me this opportunity. This talk was supposed to be done by Dr. Neeja, but because of some emergency, she couldn't come. So I'm just presenting. So I'll be talking about the implications of revised FIGO staging. As we all know that in 2018, FIGO revises staging of CA cervix with respect to the advancements in the pathology, radiology, because the initial staging was clinical, and because of the increasing availability of the imaging, it was necessary to incorporate imaging, and that led to this change? So not much has changed, but then three major things have been
Please
changed.
put it on slideshow.
Sorry, ma'am. Okay, sure. Fine, ma'am. So stage 1A, where horizontal extent of the disease has been removed, though it does not have much implications to the clinicians. Then in stage 1B, 1B3, another stage has been added. And in stage 3, 3C has been added, which includes involvement of pelvic and para-aortic lymph nodes. So I'll be dealing with these changes initially in the initial part of this talk. So the key amendments in the staging has been that the staging now allows us the use of clinical assessment plus imaging modality and or pathological findings for assessment of size of cervical tumor to assign the final staging to the patient. Similarly, in stages 1 through 3, it allows assessment of retroperitoneal nodes by imaging and or pathological findings. And if nodes are involved either by imaging or by pathology, the case will be designated as stage 3C. And in bracket, we'll write the notation like R or P, depending on radiological positivity or pathological positivity. And Swego has been generous enough to allow us the use of any imaging modality, like we can use ultrasound, TVS, TRUS, or we can use CT, PET-CT, or MRI to assess the patient. So depending on the availability and resources, a clinician is free to pick up any imaging modality. Now in stage 1, the lateral extent of tumor has been removed and LVSI present does not upstage the disease. In stage 1B, 2 centimeter size cutoff has been used, 1B1, 1B2, and 1B3. And this has been based on the oncological procedure data, because we all know that fertility sparing surgeries are best, have best outcomes conducted in stage 1B1, that is up till 2 centimeter size. And irrespective of size of primary tumor, any positive lymph node by imaging or pathology mandates upgradation to stage 3C. So that is very important, and we'll come to the implications of that. In stage 2 and the 2A and 2B, there's not much change, but yes, we have to remember that ovarian involvement in CA cervix does not impact the stage, and we should use colposcopy to assess the involvement of vagina to assess the exact stage of the patient preoperatively. And MRI is usually better for us to evaluate parametrium because infection or large tumors, they might give us some spurious reports. So we have to be careful while interpreting the imaging also. Now in stage 3C, as I have already said, that nothing has much changed except for the stage 3C inclusion. That is a new stage has come up, stage 3C, which involves includes the involvement of pelvic and or para-aortic nodes, irrespective of tumor size and extent. So 3C1 and 3C2, pelvic and para-aortic nodal metastasis, respectively. So how do we assess lymph nodes? Imaging, including MRI, CT, PET-CT, PET-MRI or ultrasound, TVS, TRUS, that can help us. In case of a radical surgery, whether we do whatever way we do, pathological assessment of nodes is now possible and is mandatory. Imaging guided FNAC is also acceptable, but we have to mention in our report that FNAC has been utilized to assign the patient as stage 3C. So use R or P notation accordingly for based on clinical assessment. And if you assign based on clinical assessment, you don't have to write anything. But if you use pathology or radiology for the assignment of staging preoperatively or postoperatively, you use the notation R or P. Now, still few dilemmas remain, like isolated tumor cells or micrometastasis. They signify low volume metastasis and the implications are not yet clear and they do not impact our staging currently. But still research has to go on for this. Differentiating metastasis for infection, especially in countries like ours, where HIV and tuberculosis is so much endemic. In those conditions, enlarged nodes are not uncommon, and so there is always some kind of dilemma with radiological assignment of staging to these patients. And sentinel nodes, if they are possible, if you have the facility, then sentinel node detection, if you are doing that, then ultra staging and IHC is mandatory for assignment of stage. Stage 4 does nothing changes. But yes, you have to remember, when the loss of fat planes with bladder is a dubious finding, and we have to be careful while interpreting this. Cystoscopy or proctosigmoidoscopy are nowadays advised for specific indications if patient is symptomatic. Cystoscopy in barrel-shaped endocervical growth or involvement of antevaginal wall is to be done, especially for 1B3 patients or the patients who have antevaginal wall involvement growth owing into the anterior fornix. So there's not much change in these. So, but what has happened after this staging was introduced, there's been a lot of changes. There's a lot of implications to the practice of gynecologist, radiation oncologist, radiologist, and pathologist. So several studies have come, several centers have reviewed their data and observed a significant stage shift and impact on prognosis across all the stages. So, using the revised FIGO staging of 2018, more than 55% of retrospectively analyzed patients' collectives were assigned to a different FIGO stage. Almost 55% patients, the staging changed after application of the staging. Out of these, 23% patients upstaged because the tumor size was more than 4 centimeters. That turned out to be 1B3. And 32% patients upstaged because of lymph node involvement. So in this study, if you see that almost 55% patients upstaged, in stage 1A1, they found that 10% patients had 3C1. And in stage 1B1, approximately 12% patients upstaged to 3C. And in 1B2, that is up till 4 centimeter, 32% patients upstaged to 3C1. Similarly, in stage 2A1 or 2, 40% patients upstaged to 3C. And in 2B also, almost 46% patients had nodal involvement. So I would say that this upstaging had led to considerable upshift of the patients to stage 3C. Now, this was the study by Koji Matsuo et al., the first publication, population-based study to examine the validity of this cancer. And it showed us very different result. It showed us a diverse range of survival outcomes for women with stage 3C. And if you see these charts, we would see that amongst the stage 3C also, because, you know, the stage 1B is now 3. 1B1, 1B2, and 1B3. And if you look into the survival rates of these 3 stages, 1B1 has 97% survival, 92% is in 1B2, and 1B3 has 83% survival. So tumor size has a significant impact on the final survival of these patients. Now, if you look into the stage 3C now, even stage 3C, depending on the size of the tumor, if you see that T1, T2, and T3, the size of tumor, the stage 3C has very different implications on that. Similarly, stage 3A and 3B and 3C, if you see, there is a significant difference in the survival outcomes. And this shows that stage 3C is a heterogeneous group. Depending on the size of tumor, if it is less than 2 centimeter, even among stage 3C1, you see that less than 2 centimeter, better survival. More than 4 centimeter, worst survival. So stage 3C is a significantly heterogeneous stage, which has impact about from the tumor size, which is very important consideration. So we cannot, kind of stratify straight away, say that it's stage 3C, and we cannot prognosticate our patients just like that it is like 50% survival. So we have to stratify our patients depending on the other factors, which is the tumor size is most important. So if you look into this study by Ayan et al., they've shown us in stage 1B1 now we can say 5-year DFS is 91%, 1B2 82%, 1B3 67%, 3C1 75%, and 3C2 it is 45%. So these studies have shown us that this revised FIGO staging has led to considerable granularity now in the prognostication part to us. So for the gynecologist and practicing gynecologist, this granularity has lot more, we can now better prognosticate our patients depending on their stage. So we can better assign our patients the exact stage of them, and we can also more accurately prognosticate our patients. Now, the stage also has implications for radiologists, because now, since imaging has been incorporated, so they have additional responsibility now to accurately assess the tumor size, parametria, vagina, nodal involvement, and metastatic spread. And whenever we are assigning preoperative staging to our patients, where we have clinical and radiological staging, then you have to remember the radiological staging supersedes the clinical staging. But we have to write the notation, stage 2A in bracket R. So if clinical and radiology is available, radiological staging up stages. And similarly, if pathology is available, then pathological staging will upstage. So depending on the pathological finding, you will assign the final staging to your patient. So in the revised staging, final staging will be based on pathology, but we have to mention that what has led to, like FNAC or final histology. Similarly, if lymph node metastasis is there and then micrometastasis is there, then we can assign the stage of the patients. And now pathologists have to perform a real elaborate analysis of all the lymph nodes. They have to take significantly, all the lymph nodes should be analyzed to exactly assign the stage now. So it poses some additional responsibility on our pathologist as well. So, and if you are doing sentinel node, ultra staging is mandatory. So because usage of ultra staging, it upstages 15% additional patients. So that has to be remembered by pathologist colleagues. So in short, I would say that there are several merits to the Swego staging system, which include tumor size, lymph node based categorization, and the incorporation of imaging and pathology. So the revised staging therefore requires meticulous and uniform assessment and reporting, not only by clinicians, but also by pathologists and radiologists. And it also provides us better distinction within stages, like 3C I told you, and reflects survival outcome more accurately than the previous staging system, with poorer outcomes as the stage advances. Thank you so much for your patient hearing.
Thank you, Dr. Seema, for that wonderful presentation. Absolutely crisp and to the point, and giving the exact information which is required today for today's good practice in the management of cervical cancer.
Thank you.
So yeah, so here I take a chance to thank Dr. Urvashi and Dr. Poonam, who have invited me to this academic event, especially to co-chair along with stalwarts like Dr. Sunita Malik and Dr. Mala Srivastav. So it's a pleasure now for me to introduce Dr. Manisha Gupta, from one TMH fellow for the other. Dr. Manisha Gupta is a senior laparoscopic and robotic gynae-oncologist at the Max Institute of Cancer Care, Shalimar Bagh and Pitampura. She has 12 solid years of experience as a gynae-oncologist, a very dynamic person. She has previously been an assistant professor at the GCRI at Ahmedabad, also a completely cancer institute. And thereafter, she's done a tenure at the Metro Hospital and Cancer Institute at Delhi. And her area of expertise is cytoreductive surgery, minimal access surgery, treatment of hereditary gynae cancers, and organ preserving management for gynae cancer. She has several membership in professional bodies and a number of publications. I introduce Dr. Manisha Gupta to speak to you on a different classification of radical hysterectomy. What's new in it? Dr. Manisha, please.
Thanks, Dr. Manners, for the kind introduction. A very congratulations to Dr. Seema Sehgal for the nice deliberation, ma'am. And I'm thankful Dr. Urvashi and Dr. Poonam to give me the platform just to clarify myself on this nice topic of classification of radical hysterectomy, because there is something new which has come up to look for it. So let me just start my screen share. Is it visible?
Yes, you have to just make it a slideshow.
Slideshow. Yeah. visible to everybody and I'm audible to everybody. So this is a very new topic, or very something new has come to this topic, that is the classification of radical hysterectomy. So radical hysterectomy as a standard treatment for the early cervical cancer has come a long way. It's a tradition for managing the early cervical cancer. So this operation has two conceptions. One is that the extended organ surgery, and the second conception is the surgery of the lymphatic drainage, that is the lymphatic territory of the organ, and that is the second conception. So from its first introduction in the year 1895 by Clark and Rice as the first radical hysterectomy, this procedure has come a long way with lots of modifications, lots of improvements in the last 10 decades. Lot of classifications have been given. The popular one and the longest being the one given in 1974 by the Piver, Rutledge and Smith, which has given the 5 classes of radical hysterectomy. Modified later in 2008, that is the Covallu and Morrow classification, which is more successful these days and more in demand these days, which had been updated in 2011 further. So just a quick review of the surgical management of early cervical cancer. In stage 1A1, that is a macroscopic disease, when the fertility is desired, we go for a radical cone or radical trachelectomy, depending upon the presence of LVSI. If fertility is not an issue, then we go for a simple hysterectomy, that is type 1 hysterectomy. Similarly, in stage 1A2, if the fertility is an issue, we again go for a radical cone or radical trachelectomy, but along with the lymph node assessment. But when fertility is not an issue, we go for some form of radical hysterectomy along with lymph node dissection. And similarly, for the macroscopic disease, that is stage 1B1, 2, and 3, we go for some type of radical hysterectomy. So if we look overall, there is a changing paradigm in the surgical management of early cervical cancer. If we want to reduce the immediate perioperative morbidity, we go for some kind of minimal assess surgery by laparoscopy or robotic. Maybe after LACC trial, there is some controversies in that, but that's a separate issue, that's a separate topic. If we want to reduce the long-term morbidity, we choose for a nerve sparing radical hysterectomy. We want to go for a fertility preservation in young girls, we choose for some kind of fertility sparing procedure. So overall, we are tending towards doing less to achieve more, but without compromising the oncological outcome for the patient. So just a quick review of the latest, the QM classification, which has been given in 2008 and updated in 2011. In this classification, the class was replaced by the types and the numbers by letters. This classification was mainly depend upon the lateral extension of the parametral resection, which is a key parameter for the classifications of this type of radical hysterectomy. Landmarks, anatomical landmarks had been described for that. Not only the therapeutic effects, but also the post-operative complications in the form of paracervical lymph node dissection or the nerve sparings were taken care of in this classification, and the lymph nodes were dealt separately as compared to the previous Pivers classification. So just a quick review, QM classification in type A, it was a minimal resection of paracervix, ureters not dissected at all, paracervix was just transected medially, vesico-uterine and uterosacral ligaments were transected flush to the uterus, no vaginal dissections, corresponds to Piver class 1. Suitable for microinvasive stage 1A1 disease or maybe after CTRT for a completion surgery for the small central recurrence. Type B, we de-roof the ureteric tunnel and transect the paracervix in the midway. Neuronal components of the paracervix were not transected. There was a partial resection, or you will say the midway resections of the vesico-uterine and uterosacrals. 1 centimeter of vaginal cuff was resected, further classified in type B1 and B2, depending upon the removal of lateral paracervical nodes. It was an inherently nerve-sparing procedure because we are not going deep down to the deep uterine vein to transect the inferior hypogastric plexus. And it was corresponding to the modified radical hysterectomy, suitable for 1A2 and 1B1, that is a less than 2 centimeter disease. Now, the typical type C hysterectomy, there was a complete mobilization of ureter. Uterosacral ligament is transected at the level of rectum and the vesico-uterine at the level of bladder. About 2 centimeters of cuff was resected, and it was further classified in C1 and C2 with or without autonomic nerve resections. It corresponds to classical radical hysterectomy, that is paver class 3, and appropriate for a bulky disease without parametral infiltration, that is B1 and B2. So if we see for just two critical steps for C1 hysterectomy, because C1 is an inherently nerve sparing radical hysterectomy, there are two critical steps were described. First, while dissecting the uterosacral ligaments, because the hypogastric nerves, they run about 1 to 2 centimeters just below the ureter. So these should be dissected and mobilized laterally before cutting the uterosacrals for C1 resection. And similarly, for during dissecting the parametrium, the inferior hypogastric plexus is situated in the dorsal parametrium and the caudal part of the vesico-uterine ligament. So this must be preserved. And how to preserve? By just dissecting the parametrium above the level of deep uterine vein, because below the level of deep uterine vein, the inferior hypogastric plexus is there. So this is the two critical steps to perform a classical C1 radical hysterectomy of QM classification. Then type D, which is a laterally extended resection, further classified in D1 and D2, but these are rarely performed because these are morbid procedures. Practically no practical indications to perform such wide radical procedures, and they corresponds to paver class 4 and 5. Lymph nodes were dealt separately by Curlew and Morrow. Level 1, external and internal group of lymphadenectomy. Level 2, apart from level 1, it involves the common iliac and the presacral group of lymph nodes. Level 3, we perform level 2 along with the inframesenteric part of the para-aortic lymph node dissection. Level 4, level 3 along with the aortic dissection up to the renal vessels. So lymph nodes dissection were described separately by the Curlew and Morrow classification. Recently, in 2021, there is a separate classification is being proposed by the MOLUM, just published in the latest issue of the journal Cancer, which depends upon the three-dimensional configuration of parametrium and paracolpium. They have replaced the term paracervix, which was reused by the QM, by parametrium and paracolpium. What was the rationale to do that? They said that both pavers, both classical classification, that is a pivers and a QM classification, they were basically depends upon the lateral extension of parametral dissection, which is easy to understand, but it was not reflecting the anatomical and surgical conceptions of hysterectomy. Further, because it is not only the lateral extension of the tumor cells are there, ventral parametrium and the dorsal parametrium, there is always some kind of tumor spread. Also, they did not meet the need of adjacent radicality according to the FIGO staging. Because the large tumors, that is the bulky tumors, B2, B3 disease, without any vaginal vault or parametrial infiltration, they need a resection of the longer part of vagina to close the vault properly beneath the tumor, so that to avoid the tumor spilling. And because of the antiflexed portion, the antiflexed part of the uterus and the vagina, the ventrally localized tumors needs a longer vaginal part resection as compared to the dorsally placed tumors of the same size and the same stage. Again, tumor with a vault infiltration but no parametral dissection, that is stage 2, A1 and A2. Again, they need a resection of a longer part of vaginal vault along with the paracolpium resection, just to dissect the blood vessels and the lymphatic drainage of the upper 1/3 part of vagina, to just complete the radicality of the procedure, so that as Dr. Seema has said, that the tumor size and the stage is a main prognostic factor. So if we do a proper radical procedure involving all the lymphatic drainages and all the blood vessels, that improves the survival of the patient. Another problem with the classical classifications were there was an arbitrary definition of resecting the lateral parametrium midway. This is the problem because the parametral spread of tumor, it never happens in a contiguous fashion. It happens either in the form of tumor cell emboli or maybe in the form of lymph node involvement. There is never a contiguous involvement of the parametrium. So dissecting the parametrium midway may not correlate with the tumor spread in the parametrium and may hamper the survival of the patient in view of compromised surgery. So in the current classification by Mollum, they have dealt with all the deficits. This classification is based upon the ventral, lateral, and the dorsal parametrial section of the parameter of the tissues. It tailors the radicality according to the tumor size, stage, localization, or vault infiltration, and they give a comprehensive description of the three-dimensional concept of parametrium and paracolpium. Just to summarize that, yeah. They have described the ventral parametrium, lateral parametrium, and dorsal parametrium. Like, okay, I just give you a picture for that. Like this. Ventral parametrium, it contains the vesico-uterine ligament. The proximal means the near part to the uterus. Distal is the further part from the uterus. Cranial limit and the caudal limit. So the ventral parametrium contains the uterine vessels at the proximal limit and ureteral junction in the bladder at the distal aspect. Cranially, it represents the peritoneum of the vesico-uterine fold, which we dissect down, and the caudal limit is again the ureteral junction to the bladder. Laterally, if we see, it is the uterine vessels at the cervical side walls. Internal iliac vessels is the distal limit. Superior vesical artery is the cranial limit, and the vaginal vessels are the caudal limit for the lateral parametrium. Below the parametrium will be lying the paracolpium. Like below the ventral parametrium will be the ventral paracolpium. Below the lateral parametrium will be the lateral paracolpium, and similarly for the dorsal parametrium. So the cranial limit of the parametriums will be the caudal limit will be the cranial limit for the paracolpiums. So this is how it goes. Ventral paracolpium, the proximal limit will be the vaginal vessels, not the uterine vessels, because it will be deep down. Distal aspect again will be the ureteral junction with the bladder. Cranial limit again ureteral junction with the bladder, but the caudal limit we have to go up to the inferior hypogastric plexus if we want to resect the caudal limit of the ventral paracolpium. Lateral paracolpium, the deepest part will be the pelvic splanchnic nerves. We have to resect the inferior hypogastric plexus for that. Similarly, if we want to resect a complete dorsal paracolpium, we have to go deep down up to the endopelvic fascia. So this is the pictorial description of all the lines. I think it will be very difficult for all of you to imbibe that in such a short span of time. So just what is there in that, this classification gives the 4 types of radical hysterectomies. Type 1 is equivalent to, that is class A QM classification, simple hysterectomy with minimum parametrium margins. Only the proximal aspects of the 3D parametrium is resected with minimal vaginal vault resection, suitable for the microscopic stage 1A disease with no LVSI. Type 2 is a typical radical hysterectomy. It corresponds to the Wertheim's and Meeks operation of Pivot's classification. In this, we resect the distal aspect of the newly described parametriums, not the paracolpiums. No paracolpiums are resected in the type 2 radical hysterectomy of Mollum classification. So ventral parametrium is resected up to the ureteral junction, lateral parametrium up to the internal iliac vessels, and dorsal up to the rectal side wall. We go laterally, but we do not go in the depth for performing this type of hysterectomy. Suitable for stage 1A with LVSI and the low volume disease, which is located dorsally, means on the posterior cervical lip. Because of the antiflex posture of the uterus, we need not to resect much length of the vagina. Type 3, it corresponds to the typical type C1 radical hysterectomy, means in this we remove completely the ventral, lateral, and dorsal parametriums up to the distal limit of parametriums, but we remove only the proximal aspect of the paracolpium, allowing a resection of a longer vaginal vault up to 4 centimeter. Vaginal vessels and the inferior hypogastric plexus is identified and spared because it corresponds to C1, so it has to be a nerve sparing kind of hysterectomy. It offers to resect an adapted length of vagina to cover the big tumors. So it is suitable for stage 1B, which is ventral localization, because 1B1, that is a small volume disease, but located ventrally, we need to have a longer vagina. And 1B2 and 1B3 with dorsal localization, because of the posterior location, but large volume, we need not to resect posterior, because posteriorly, because of antiflex posture, always the larger portion of the vagina comes out. Type 4, in this, resection of the distal aspects of parametrium and resection of the distal aspects of all the paracolpium has to be performed nerve sparing unless there is a direct infiltration in the paracolpium and the pelvic fascia. It is suitable for the ventrally located 1B3 and stage 2A. If there is an invasion of the stroma or the vault, we need to not to perform nerve sparing. Otherwise, it has to be a nerve sparing. We have to locate the inferior hypocrestic plexus deep down to deep uterine vein and lateralize that. Just to summarize, type of radical hysterectomy, type 1, only the proximal aspects, nothing else, minimal resections suitable for 1A with no LVSI. Type 2, only the parametriums are resected at the distal aspect, no paracolpium, minimal resection of vagina, stage 1A with LVSI and 1B with dorsal localization. This is for small tumor load. Stage 3, distal aspects of all the parametriums, but proximal aspects of all the paracolpium. 2 to 4 centimeter vagina, because we need to have a longer vagina for 1B1 ventral tumors and 1B2 and 3 dorsal tumors. Stage 4, distal aspects of all the things, 2 centimeter below the tumor border, not the 2 centimeter of vagina, but 2 centimeter below the tumor border, suitable for the larger volume tumors which are ventrally located. So just to conclude, the new classification is based not only on lateral resection, but also on the depth of resection in small pelvis, taking into account the 3D parametrium and paracolpium template and the comprehensive description of parametrium, paracolpium, and pelvic autonomic system. Also takes into account the FIGO 2018 staging and tailor the surgery according to the tumor stage, volume, localization, and tumor spread in the vaginal vault. New classification does not identify nerve sparing as an option, but it takes it at a standard of care for all stages unless there is a direct infiltration in the paracolpium and pendopelvic fascia. Lymph nodes are dealt separately as if by the QM classification level 1, 2, 3, 4. Depending if level 1 is involved, you go to a higher level. If level 2 is involved, you still go to a higher level. So that's the thing I can do within 10 minutes. Thanks, Dr. Urvashi, to give me such an extensive thing for just to cover in 10 minutes. Thank you all and happy Diwali.
Thank you, Dr. Manisha. You have very excellently covered all the classification. Now time has come that we were writing just modified Vardime hysterectomy, in all. So you have to be now, it's important to write down what level you have done the dissection and Curlo Marrow. Yes, we are picking up that. We have started doing that. But yes, this latest NULM with the 3D involvement of parametrium and paracolpium involvement.
Staging has involved, or they have evolved the radicality of surgery according to that. That is what.
And then prognosis also depends on how much radicality we have done and all those things. And Seema, you have nicely described the classification, the changes that are there, which has size is important. Now lateral spread is no longer seen, which was done earlier. And of course, the variant involvement is no longer a factor. Vagina, yes, we have to look for. That's the part, which is missed by our postgraduate students. They don't look at the vagina. It's very important before doing surgery. Do the colposcopy of vagina also, and while doing the radical hysterectomy, then also it's better to start from the vaginal side. Give a incision below the involved part and then go up. That's what we do, dissect from below and then they do go from above. Of course, we are not doing MAS. And another thing is about PET scan. Yes, but don't go for PET scanning primarily for radiological imaging because inflammatory lymph nodes may also be picked up by the PET scan. And that's very important. So now the time is there for the radiology people as well as the pathology people also to be doing implications for them also to be very thorough in telling us what is there. Yes, Dr. Manish, you wanted to say something?
No, ma'am, I think you have summed it up very nicely. The topics were excellent, and they've both the speakers have done justice to it. In case there are some question in the chat box, ma'am, you can coordinate it.
Dr. Poonam, do we need to do it
Yes.
now or at the end of the?
Ma'am, we will do at the end of the session, ma'am.
Okay. Thank you very much.
Thank you, ma'am. Thank you, Dr. Sunita, ma'am. Thank you, Dr. Seema, Dr. Manisha for nice talks. And thank you all the chairperson for conducting this session so nicely. Now I hand over the mic to Dr. Urvashi. Dr. Urvashi will conduct the panel on cervical carcinoma cervix cases. Dr. Urvashi is a senior specialist in Deendayal Upadhyay Hospital, my very dear colleague. She is a gynae oncosurgeon, a very good clinician, a very good surgeon, and above all, a very nice human being. All to you, Dr. Urvashi, stage is all yours.
Thank you, Dr. Poonam, for the kind words. Hello, am I audible? Yeah.
Yes, you are audible.
Just a second. I think my screen is not moving. Just a second. Are you able to see my screen? To strengthen our fight against the menace of cancer, we have a team of esteemed panelists who will enlighten us with their expertise and their exemplary clinical acumen. We have before us, with us, Dr. Amita Suneja. She is HOD Director Professor in University College of Medical Sciences and GTB Hospital. She is a fellow in gynae oncology, a great orator and a commendable teacher. She is a recipient of many prestigious awards. We have Dr. Rupinder Sekhon. She is a fellow in gynae oncology, chief of gynae oncology unit at Rajiv Gandhi Hospital. She is a wonderful clinician and a fabulous surgeon. Dr. Poonam Lal, she's senior specialist at Deendayal Upadhyay Hospital, recipient of Abdul Kalam Award. She's an academician and teacher par excellence, and I'm really fortunate to be working with her. Dr. Kanika Jain, she is senior consultant gynae endoscopic and robotic surgeon at Gangaram Hospital, recipient of the APJ Abdul Kalam Award. She has held many executive positions in the past and is currently chairperson endoscopy committee. Dr. Vineet Talwar, who is the head of the Department of Medical Oncology at Rajiv Gandhi Hospital, and his exemplary work in the field of oncology has been celebrated with the Chikitsa Ratan Award. And last but not the least, we have Dr. Swarupa Mitra, who is the Director of Gynecological Radiation Oncology at Rajiv Gandhi Hospital. With more than 600 presentations, she is also a member of the advisory committee for the Government of India for Health Communication. So without much ado, I begin the panel discussion. So coming to the first case, we have Mrs. P, 60-year-old, para 3, live 3, came to us with a history of postmenopausal bleeding for 6 months. There was no history of discharge, bladder or bowel complaint, no comorbidities, a good performance status. General physical examination was normal. Local examination showed a 3 to 3.5 centimeter growth on the interior lip of the cervix. PVR showed a supple parametrium. The histopathology of the cervical biopsy revealed a grade 1 squamous cell carcinoma. So Dr. Amita ma'am, I'd like to know how will you investigate her further? And besides anesthetic fitness, when a clinician orders the investigations, what is the chief aim of investigations in a case of carcinoma cervix?
Thank you, Urvashi. And at the outset, I must thank the organizers, Dr. Poonam, Urvashi, and AOGD team for inviting us. And this particular case is histologically proven squamous cell carcinoma cervix, and it is well differentiated. And if we see the clinical picture, FIGO stage 1B2, it is as per clinical staging. And we will investigate her to know the extent of the disease. Imaging is now part and parcel of the staging. So I would like to know, and out of imaging, MRI facility is there. It will be the best option for her. And pelvis and abdomen. You know, MRI is better in showing us the tissue characteristics, better than CT scan. And so while we can know the tumor volume exactly, and whether there is stromal infiltration or not, whether there is extent to the vagina or to the corpus, that we can know by MRI, and what is the parametrial infiltration, and the most important, the lymph node status. So that we have to see. So once you order the MRI, if it is or CT we can do, but depends upon the resources available. Always look at the kidneys. Sometimes we might miss hydronephrosis. So that is important. And for distant metastasis, like routine X-ray chest will be mandatory in all the cases. That will be investigation for preoperative workup also. And PET CT is not required in this case. She's early cancer. So I would reserve PET CT for locally advanced cancer and before ordering chemo radiation. In those cases, PET CT will be required, but not here in this as a primary modality for investigation. And amongst the sero markers, HIV is must.
Right.
All cases of malignancy.
Absolutely.
Those are the investigations which will be.
So as very nicely told, ma'am, so all the biochemical and the viral markers and hematological investigations were normal. CECT for this patient showed a 3 by 3.5 centimeter growth in the cervix. The parametrial bladder and rectal planes were well maintained. There was no evidence of lymphadenopathy. So we came up with the provisional diagnosis of well-differentiated carcinoma cervix stage 1B2. So I'd like to know, ma'am, what factors will you consider when you decide between surgery and radiotherapy for this patient, knowing that in the early stages, both have equal survival? And also, if you opt for surgery, would you like to do a nerve sparing for her and a sentinel lymph node in this case?
Okay. I would love to do surgery for this case. Ideal case, she is not old, 60 years, and it's a resectable tumor. It's just 1B2, and the parametrum is free, and functional status is good. There's no comorbidity. So advantage of surgery in this case will be both will give cure. That you very rightly said, and will be removing the primary disease. We'll be taking it out. Second, we'll get a specimen, which will tell us whether what is exact size of the tumor, what is the stromal infiltration, what is the status of lymph nodes, and whether parametrium is involved or not. So we can tailor the adjuvant therapy. And it will avoid the complications, long-term side effects of radiation, like bowel enteritis, proctitis, or cystitis. And if I don't know whether she is sexually active or not, vaginal health, sexual health is definitely better with surgery. So both will give the same cure, but I would like to do surgery in this case. And we'll go for open radical hysterectomy, type C. And your question was, would I do nerve sparing surgery or it is the C2? When you do nerve sparing surgery, it does mean we are doing radical hysterectomy, which is conservative.
Absolutely.
Ideally, it is suited to B1 tumors, but in B2 also, like in this patient, the size is not really, though it is from 2 to 4, but we can tailor it in this case. Like when we do radical hysterectomy, I would like to cut the uterosacrals at the level of rectum only, so we can save the superior hypogastric plexus, and then open the Okabayashi space, and you can dissect till the upper level of uterine vein and save the inferior hypogastric plexus. But then you go to the vaginal, psychovaginal space. We have to remove 2 to 4 centimeter. In this case, you can remove 3 centimeter of vagina. Maybe in that space, we won't be able to spare nerve to bladder. So that might be sacrificed. So you can always tailor your surgery. Even literature says up to B2, like recently Manisha has said, all types of hysterectomy should try to spare the nerve. So you look and try to spare the nerves, but don't compromise on the oncological safety.
Absolutely.
So that would be my answer. Regarding the sentinel lymph nodes, it's not a standard of care. It's still experimental in CA cervix. And if you, till B1, this SLN mapping has been validated. So many centers are doing it. But then the question is that you should have in-house validation of SLN. Like we don't do it. We don't have our comparison results with lymphadenectomy. And second, if you do it, then for MIS, you should have isocyanide green dye and fluorescent camera. That is standard. Methylene blue is not good. Otherwise, for open, it should be radiocolloid technetium labeled with gamma probe. So SLN we are not doing, and I'll do lymphadenectomy systematic in this case.
Okay, absolutely, ma'am. Very well said that we need to tailor the surgery, and one size fits all doesn't suit the CS cervix anymore. So if in this case we know the growth is more than 2 centimeter, and the LAC trial has clearly said that yes, we have to do open surgery. Now the controversy is going on, as we all know, that for growths less than 2 centimeter, there are a lot of studies which say that yes, we can still go in for minimal access surgery. Now, what is your opinion on this?
Yeah, if you see the laparoscopic approach to cervical cancer trial and other landmark series, even in early stages, they say disease-free survival and recurrence rate is more, disease-free survival is less, and standard of care is open radical hysterectomy with lymphadenectomy. But there's a sucker trial which who have put this slide, which is surgery in cervical cancer comparing the MIS surgery, including robotic surgery, with open radical hysterectomy. And they have also clearly said that even if growth is less than 2 centimeter, the disease-free survival is less and recurrence is more in cases of MIS as compared to open hysterectomy. But they have even taken a separate data for the patients where they use the protective surgical maneuvers, like covering the growth with the colpotomy or using the laparoscopic staples and not using manipulator. In those particular set of patients, the disease-free survival and recurrence was similar to open hysterectomy. So standard of care is that we do offer open hysterectomy, and then we will only do MIS in setting of clinical trials. And if some good centers are doing MIS, then we have to really counsel the patient, give them what the literature says, and let them make the decisions. So then only the MIS should be done in very early.
Absolutely. Very well explained. We need to counsel the patient to go in for MIS for CS cervix. So this patient's type C2 radical hysterectomy was done. The final histopathology was a grade 1, 3.2 by 3.8 centimeter tumor with depth of stromal invasion 8 millimeter out of the 1 centimeter cervical wall thickness. There was no LVSI, all margins were negative and all lymph nodes were negative for the tumor cell. So Dr. Swarupa, I would like to know from you, according to you, does this patient need adjuvant radiotherapy after this surgery has been done?
Good evening, everyone. So, nowadays, we have, am I audible?
Yes, you're audible.
Yeah. So, nowadays we have very clear-cut, very definite indications of adjuvant radiation or radiation chemotherapy. So, for this patient, according to the any guidelines, NCCN guidelines or ASTRO guidelines, we follow the Sedley's criteria. So, for this patient, her LVSI is she does not have an LVSI, although the middle 1/3 is involved. And the tumor size is less than 4 centimeters, 3.8 centimeter.
Yes.
So ideally, she does not need radiation. Okay. But I guess the tumor size, it is 3.8 centimeter. So probably I would not give radiation. But if the surgeon feels, because now the tumor size, according to the GOG 92 protocol, they used to take the clinical palpation. But nowadays, the MRI finding, MRI dimensions, and also the pathological dimensions, they are taken into account. So probably, she does not merit a radiation.
Okay. Thank you so much, ma'am. So Dr. Poonam, I'd like to know, we have done surgery for her. The radiotherapist has said she doesn't need radiotherapy. So now how frequently will you call the patient for follow-up, and what protocol are we going to follow at each visit?
Dr. Rishi, that is a very important aspect of this patient. We have done the surgery. Now we are going to discharge. Naturally, the patient would like to know how frequently she needs to come. So initially, she is called 3 to 4 monthly for first 2 years, then 6 monthly till 5 years. And after that, the follow-up is recommended follow-up is yearly till life. Now, on every visit, what we want to know is that we want to take her history. We will do thorough examination. The purpose of follow-up visit is that we want to address to her treatment-related complication issues, her psychological health, her psychosexual morbidity. We want to treat that. And also we want to see if there is any recurrence. There should not be any recurrence. Now, how to detect the recurrence? So annual cytology, some people recommend, but it is of limited value. By the time this annual cytology that's come positive, disease is already symptomatic. And we want to detect when it is asymptomatic and in the treatable stage. So though routine imaging is also not recommended, but interval imaging in high risk cases is done. to detect the disease in the earliest possible stage where we can handle it to cure it.
Thank you so much, Dr. Poonam. So to summarize what we learned from this case, the aim of investigation in a CS cervix patient is to identify patients with high-risk features and spare them from combined treatment. Age, performance status, resources, and fertility concerns help us to decide between surgery and radiotherapy. Nerve-sparing radical hysterectomy ideally can be done up to stage B1, but as ma'am said, we can tailor it according to the disease. Minimal assessed surgery is associated with worse disease-free survival even in stage 1B1. And if we go for it, patient has to be thoroughly counseled about the available data. Sentinel lymph node to be done only after in-house validation of at least 25 cases, and best detection rates are seen in tumors less than 2 centimeter. And lastly, adjuvant therapy has to be decided according to the risk factors. So coming to the second case, she was a 31-year-old nulliparous female with blood-stained discharge per vaginum for 6 to 8 months. There was no comorbidity. The general physical examination was normal. Local examination, ectocervix was healthy. There was no obvious growth. Internal examination was normal. A pap smear showed a Agas report, and a colposcopic directed biopsy and ECC gave us a report of adenocarcinoma with evidence of microinvasion. On MRI, there was no evidence of parametrial or distant spread, and there was no evidence of lymphadenopathy. So Dr. Rupinder ma'am, I would like to know how will you manage this case? And we all know that we do offer fertility preserving surgery in squamous carcinoma. But in adenocarcinoma, we are still not that sure, or we don't have that much literature. So can we do the same in adenocarcinoma also, seeing the report of this patient?
Yes, actually for microinvasion, whether it is squamous cell carcinoma, adenocarcinoma, or even adenosquamous histopathology, we can do a fertility sparing surgery in all three cases. It is only when we encounter a neuroendocrine tumor or maybe a gastric type of adeno-CA or maybe a small cell carcinoma or something like that, that do not offer any kind of conservative surgery to such patients.
Right, ma'am. So if we are, as ma'am said, we can go in for a fertility preserving surgery for her. So if you do a fertility preserving surgery for her, then how frequently to follow her up? And is hysterectomy absolutely essential on completion to childbearing, or if she agrees for follow-up, we can leave her?
See, as far as follow-up is concerned, the protocol is the same as what Poonam had said, every 3 months for the first 2 years, followed by every 6 months for the next 3 years. As far as doing hysterectomy is concerned, after childbearing is complete, it depends on several factors. The first most important factor is that a persistent HPV positivity, even if you do not have any cytological findings for the patient. So if there is a persistent HPV positivity, you would definitely offer a completion surgery for her. Because smears and all, even if you do an LBC, it may not necessarily detect an adeno-CA.
Absolutely.
Right? Because that adeno-CAs are notorious for affecting the endocervix rather than the ectocervix, especially in younger patients. And then what we have to remember is that in adeno-CA is far more aggressive than a squamous cell carcinoma, is much more difficult to treat than a squamous cell carcinoma, and also recurrence rates are much higher in adenocarcinomas than in squamous cell carcinomas. So keeping all these factors in mind, it is important that if the patient does have an adeno-CA, and she has either a persistent positive smear, whatever the smear might be, any type of abnormal cell, regardless of what type of abnormal cell there is, or if there is persistent positive HPV findings, then we should definitely offer her completion surgery after childbearing.
Okay, thank you so much, ma'am. So for this patient, after lymphadenectomy, we went ahead with a cold knife conization with ECC above the cone. It was a HPV associated grade 1 adenocarcinoma with no LVSI and invasion up to 2 millimeters. So to summarize,
can I just interject over here? So Urvashi, I want to know that in your very slide, you said that she had Agas.
Yes,
right?
ma'am. She had Agas. Yes, ma'am.
So did you do an endometrial sampling?
Yeah, endometrial sampling was done, ma'am. Yes, for Agas we have to do endometrial sampling, or ECC, and
so that over there.
Yeah, so it was, yeah, we did endometrial sampling.
So how did you do the endometrial sampling?
How, ma'am, I didn't get you.
Yeah, how do you usually do endometrial sampling? I mean, you do a PIPL or do you do a histro or?
Ma'am, we don't do a histro. We use a number 4 Carmen cannula or a PIPL, and we do if we are not getting enough cells with it, we go in for a DNC also. Because these days, earlier it was said aspiration is giving you a higher result, but recent guidelines say if you don't get tissue, DNC is the protocol to do sampling if you're not getting enough tissue. So we have to evaluate the glandular cells, the source of the abnormal glandular cells.
So my viewpoint is a little different.
Okay, ma'am.
What I'm saying is that, you have got agas. So that means there would be some abnormal glandular cells, right? So again, whether you're doing a blind DNC or you're doing a PIPL sampling, you will not know, number one, the site of the lesion and also the extent of the upper extent of the of any endocervical lesion. You have done a cone, right? So fortunately, I'm presuming that the upper margin of the cone was negative.
Negative, yes, ma'am, it was negative.
Right, but if you have a AGIS report, you might not be fortunate enough to get a negative upper margin.
Okay.
Also, you would not have actually assessed what should be your upper margin.
So hysteroscopy should always be
done. No. When we are doing a cone for this microinvasive lesion, which is actually the correct treatment, it is very important that we should be sure that that the cone goes right till the internal os, presuming that this is a cervical cancer. But if you got some abnormal glandular cells, don't you think you should be doing a little more thorough and perhaps do a hysteroscopy? I don't know. I would like to have the opinion of the panelists as well.
I'd like to have the opinion of Dr. Amita and others, whether we should go in for hysteroscopy for all such cases.
I think if on transvaginal sonography, if it is a regular endometrium, then no focal thickening, you can do blind sampling. But if TVS shows that there is a focal thickening, then only hysteroscopy should be put in.
Okay, right, ma'am. So, anybody of the panelists who wants to give any other input, ma'am, on this query? So, as ma'am said,
so I agree with what Dr. Amita had to say, but my only why I brought out this point was only that once you have a report of AGIS, we should definitely be more thorough.
Definitely, ma'am. So point well taken. So in case we have an AGIS report, for the benefit of all postgraduates, it needs to be evaluated thoroughly. We should know the source of the abnormal cells. If we are very sure the endometrium is normal by a scan and we can leave a hysteroscopy, then only a blind DNC should be done. So to summarize, in fertility preserving surgery, aim is resection with adequate free margins and preservation of the upper part of the cervix. It can be done in squamous and HPV associated adenocarcinoma. In squamous carcinoma, at the end of childbearing, hysterectomy is optional, but it needs to be done on completion of childbearing only if we have chronic persistent HPV infection and persistent abnormal pap smears. But in adenocarcinoma, it is mandatory as pap smears and colposcopy are less reliable. Well, thank you, ma'am. So
can I say, it's very important. Leaving adenocarcinoma, you are sitting on a volcano.
Absolutely.
And your pathologist, always talk to the pathologist how meticulously they have, sectioned the cone.
Absolutely.
Because otherwise,
I absolutely agree with what Dr. Amita is saying. That is all the more reason why it is very important to assess the endometrium. See, you are looking at CA histopathology in your cervical cancer also. So one has to be very sure what is the uterine extension, if at all there is.
Of the tumor, right.
So coming also, Dr. Urvashi, this is associated with some adenocarcinoma with skip lesions. So
yes, we need to.
So ma'am is very right. Ma'am is very right in saying that we must assess the endometrium.
Right. So coming to the third case, she's a 62-year.
The vagina as well, but I didn't mention the vagina because that has already been addressed. I think I'm not sure, one of the speakers, or I think perhaps it was Dr. Amita who said that before we actually do the hysterectomy, we should do a colposcopy.
Yes.
Yeah.
Right.
Dr. Manisha said that.
Yeah. No, that Seema said.
Colposcopy.
Seema said.
Yes. Even if we don't do a colposcopy, sometimes that is not quite possible in the theater. If you just apply some acetoacetic acid on the vagina, that also can give you a lot.
That also tells us very nicely. Yes, ma'am.
Yeah. It's very easy to do.
Very easy to see.
Yeah.
Absolutely. So this is a 62-year-old female with dirty, foul-smelling discharge per vaginum for 8 months. She attained menopause at the age of 54 years. She's a known hypertensive for 10 years, controlled on tablet amlodipine. Good performance status with the normal general physical examination. Local examination showed a 4.5 to 5 centimeter exophytic growth involving the cervix. On PVR examination, bilateral parametria was supple. Biopsy showed a grade 2 squamous cell carcinoma of the cervix. MRI showed a 5.5 by 5.5 lesion in the cervix, parametral bladder and rectal planes maintained with no lymphadenopathy. So, Dr. Kanika, I'd like to know what stage will you assign to this tumor, and would you like to go in for surgery for her, given that there is no lymphadenopathy and all planes are maintained?
Well, I would give this, since she is quite well maintained with a score of 1, and the diagnosis in her case being moderately differentiated squamous cell carcinoma. According to the size, I would give her a stage 1B3. Yeah. But considering that you're saying that there is no pelvic lymph node involvement seen on the MRI and all, but I would still maybe suspect maybe a vaginal involvement or maybe a lymph node involvement. So I can upgrade it to 2B as you're writing, but I would give it 1B3 and label it as a locally advanced cervical cancer.
Absolutely. No, 2B, this I've written for the locally advanced cancer is stage 2 thing, but this 1B3.
I would label it as 1B3.
Absolutely, this is 1B3, right? And so you like to go in for surgery for her, or?
No, not in her case, especially with the, I mean, it's a locally advanced cervical cancer. And in this case, a combined chemoradiotherapy would be the treatment of choice. But prior to that, we have to investigate her further. Since the size of the growth is quite good, so I would like, if possible, to do a cystoscopy and see the bladder involvement. Sometimes it's not given in the MRI, but if we do in an endoscopy and we find that there is a puckering or a growth there, so that needs to be evaluated first. And with the comorbidities and all, I think a chemoradio would be a good choice for her.
Okay, and, right. Thank you, Dr. Kanika. So, Dr. Swarupa, I'd like to know, like, if we are posting this patient for CCRT, so what are the patients are quite scared of the side effects of radiotherapy. So, I'd like to know what are the recent changes which are being made in the radiotherapy protocol to increase the efficacy and decrease the adverse effects for the CA patients.
This is, I'll really take this opportunity to speak about the changes that radiation has these days. So since the last 5 or 6 years, we have evolved quite a lot with the EMBRACE-1, retro-EMBRACE, and now the EMBRACE-2 studies. So for a good response or for a good treatment, which we say, we need to give for a locally advanced about 80 to 85 grays of radiation. This is including the EBRT and the ICRT, that is the brachytherapy. And also, not only the maximum dose, we need to see, because this is a curable tumor, so we need to see that the morbidities, that is the genitourinary morbidities, the bladder and the rectal morbidities, bowel morbidities are to the minimum. So hence, the treatment protocol or the treatment method should be such that we can target the tumor very well. And also the areas to be treated, like the lymph nodal areas, the better we target it, the more advantage we give to the protection of the normal structures. So now how do we target it? So previously we used to do a 2D CRT or 2D radiation that was with the help of an X-ray. Then we gradually graduated to the CT-based radiation. So the results were a little better. But now, after the EMBRACE studies, we are using we are using the MRI guided. So MRI guidance has actually given a lot of advantage to local control, metastasis, and also the overall survival. So with the use of MRI for targeting, that is for the contouring, not only for the external radiation, but also for the ICRT, we are able to decrease the CTV volume, the PTV volume also. And this is the same with the ICRT. Now, this is about the MRI. But another thing which we have, which are doing now, and this is after the EMBRACE-2 protocol, that is the image-based adaptive radiation. That is, we are doing the scans after each ICRT fraction. So in this way, like between two ICT fractions, the tumor does shrink. So we do, ideally we should be doing an MRI, but in our hospitals, in our setup, we cannot do it because of the cost. So we are doing a CT scan. So that is why we can actually target the tumor very well, even when it is shrinking. So these are the main changes we have. That is the imaging with MRI and also the guidance of the ICRT with MRI and imaging. And the third is the adaptive radiation. And the fourth phase is the image guided, because we know that is the bladder protocol we do follow and the rectal protocol we do follow during the radiation, but it is not absolute with many patients. The image guidance during treatment gives a much more advantage as far as the tumor shrink is and the local control is concerned.
Okay, thank you so much, Dr. Swarupa. Now, I'd like to know from Dr. Vineet, which so much going on about neoadjuvant chemotherapy in bigger tumors. Do you think we should give her a neoadjuvant chemotherapy and then do a surgery for her? What does evidence say, and does it result in better survival than CCRT upfront?
There has been a Cochrane review analysis, and that has conclusively told that the neoadjuvant chemotherapy is definitely inferior to chemoradiotherapy. In fact, there was a trial which compared chemotherapy followed by surgery versus radiotherapy, and that showed inferior disease-free survival benefit.
Right.
Of course, there are a lot of trials which show that there is a marked improvement when you give chemoradiotherapy versus radiotherapy. We talk of the absolute survival benefit. You know, there is a progression-free survival. You have the overall survival, but you talk of the absolute overall survival benefit, which has a very high power of academic correlation. You have 8% absolute overall survival benefit when you give chemoradiotherapy versus radiotherapy in these patients. So the role of neoadjuvant chemotherapy would be suspect in these cases, and those areas where they are bereft of radiotherapy machines, or probably like in the government centers where there is a huge waiting list for radiotherapy in these patients, probably there I think the role of neoadjuvant chemotherapy comes. Otherwise, given a choice, it is always better to go for chemoradiotherapy.
Okay, thank you, Dr. Vineet. So to summarize, I'd like to say that CCRT is the treatment of choice for locally advanced cervical cancer. Embrace protocol should be followed to decrease adverse effects. EBRT should not be used for parametrial and tumor boost. And CCRT results in superior disease-free survival than neoadjuvant chemotherapy in locally advanced cervical cancer. So our next case was presented in NSGO 2020. I have taken from there. She's a Mrs. 38-year-old primary gravida with 18 weeks pregnancy, presented with irregular spotting for 1 month. There were no obstetric causes of the bleeding, and on per speculum examination, there was a 2 by 2.5 centimeter growth on the anterior lip. PVR was normal. PAP showed HSIL. So colposcopic directed biopsy showed a grade 1 squamous cell carcinoma. MRI showed no evidence of parametrial or distant spread, and there was no evidence of lymphadenopathy. So Dr. Kanika, this patient is really keen on continuing the pregnancy. How would you manage this case? And if required, can we do a laparoscopic pelvic lymphadenectomy in pregnancy?
Well, that's a very nice case, and thank you for asking me. This patient actually, we have to really counsel her well. This patient falls into the category of stage 1B2, and any such patient with 1B2 and above, we have to have a multidisciplinary approach with her. But first and foremost, we need to counsel her. She needs to know what her disease is and what is the prognosis and what are the implications of continuing with the pregnancy as well as not continuing. So both ways we have to explain the things to her, and then it should be her decision. Since you're saying that she is very keen on continuing the pregnancy, then in that case, we would like to start with a multidisciplinary approach, taking into conference. I mean, we have to involve the fetal medicine specialist, the neonatologist, and the oncophysician, And we have to also maybe further counseling part, and to give her some psychological support, we have to maybe involve a psychologist also in this case. And then we have to definitely a laparoscopic pelvic lymphadenectomy. You said 18 weeks, right? So at 18 weeks, yeah, in the second trimester, it's easy to do laparoscopic pelvic lymphadenectomy. Up till 26 weeks also we can do it. And we do the pelvic lymphadenectomy with the intra-abdominal pressures, preferably within the range of 12 to 14 millimeters of mercury, not beyond 15. And it should be a moderate Trendelenburg's position, and it should be done hastily. I mean, there should not be more than, and it would not take more than an hour, but within 90 minutes, we have to finish the case. And then we would advise her to continue with the if there is no nodal involvement detected after the laparoscopic lymph node staging, then we can continue with the neoadjuvant chemotherapy. And another option is if she doesn't want to go in for a laparoscopic lymphadenectomy, then we can straight away continue with the neoadjuvant chemotherapy, and we can defer the surgery till 6 to 8 weeks after delivery also. And then this neoadjuvant chemotherapy needs to be given every 3 weeks for a total of 6 doses, or we stop short at least 3 weeks prior to delivery. And yes, we would like to deliver her earlier, depending on the salvageability of the nursery facilities that we have at 32 or 34 weeks. Whenever the baby can be salvageable, then we should not give the chemotherapy 3 weeks prior to that. And so that the bone marrow, the toxic effects of the drugs on the fetus as well as the mother, they get some time to recover. The placenta can metabolize and decrease the toxicity levels of the drugs before the child is delivered. So that time needs to be given. And if she goes till 32 weeks, which is a good salvageability level in our nursery, then we would like to do a cesarean for her. She should not be given an option of vaginal delivery, and a cesarean, and that to a classical cesarean, and followed by a radical surgery there and then, or maybe it can be done at a later date, 6 to 8 weeks post-delivery.
Right. So I'd like to know from Dr. Vineet, like what neoadjuvant chemotherapy would you like to give, and is it safe during pregnancy? Dr. Vineet, please.
Yeah, can I just interject over here?
Yeah, ma'am, please.
See, I'm not very sure that even attempting, let alone doing laparoscopic lymphadenectomy for a 18 to 20 week pregnancy is going to give us any benefit whatsoever.
Right.
So I would think that, we should straight away go in for neoadjuvant chemotherapy, give her 3 cycles. That would, bring her up to a little more than 32 weeks. At 32 weeks, it would be a viable baby, and we can just follow with a cesarean radical hysterectomy.
And a prophylactic steroid also to enhance the
as well as, of course, a bilateral pelvic lymphadenectomy, and see the histopathology and take it from there.
Absolutely, right. Absolutely, ma'am. Dr. Amita, what is your opinion on
these measures of, trying to do a laparoscopy? I mean, what good would it do if the nodes are, then what? And
no, I'll tell you. See, even I was of the same opinion before I read the literature, Dr. Rupinder, that we should directly give her neoadjuvant, that for how long she'll continue. That was the doubt. But if you see the guidelines, and they say the idea of doing lymphadenectomy is if lymph nodes are positive, then you can't continue pregnancy.
Right. Terminate straight away.
Yeah, you terminate straight away. That is the advantage.
Yeah,
but the literature, but in the up-to-date, it's given that you can continue with neoadjuvant chemotherapy even if the nodes are positive.
No, I didn't read that. I don't think the guidelines say that, because if lymph nodes are positive, she is 3C. No.
Yeah.
So life is more important than having this baby.
It's our choice to continue with the pregnancy, so we can.
No, but we are such a patient, and she's just 18 weeks. I'm not very sure that with the cervical cancer, many would want to continue with the pregnancy.
Yes, most of the time in Indian setup, they would like to get it aborted. But if this patient has opted for continuation of pregnancy, then what are the options?
Then that a patient does opt for a continuation, instead of doing a full-blown pelvic lymphadenectomy, just doing an image-guided FNAC from the lymph node and finding out which is whether it's positive or not. That is the highest level of the enlarged lymph node. We can do an FNAC. If it is a positive, we terminate the pregnancy.
Okay,
But
right.
doing a what my idea was that doing a full-blown laparoscopic pelvic lymphadenectomy somehow does not seem rational. Of course, we need to sample the lymph nodes if they're enlarged, and that's what you found out on imaging. Definitely. And if there is lymph node positivity, there's call for termination of pregnancy and so on and so forth. But just to do a bilateral laparoscopic pelvic lymphadenectomy, just like that, I'm not very sure.
Okay, so if we have a less, we can do a minimally invasive approach like a CT guided or a MRI guided, sorry, BAPS.
No, that will be possible if lymph nodes are enlarged. Here, MRI shows lymph nodes are not enlarged.
Not enlarged.
So either counsel the patient that she is taking a risk. If there's a micrometastasis, she's taking a risk and then she's continuing the pregnancy.
Right, right. So we have to counsel. Counseling is the key. If the, like ma'am said, in Indian setup, most of the patients would like to abort at 18 weeks. But if the patient agrees to continue, then we have to counsel her that in case she's not going in for lymphadenectomy, there is a possibility that she has positive lymph nodes and is still going in for the neoadjuvant.
No, how many centers are doing ultra staging and thereby looking at micrometastasis as of now? Let's be practical on that.
Absolutely, ma'am. Right.
Yeah. Hardly any, I think. But yes, speaking, yes, you should do lymph node sampling and look for micrometastasis, and if positive and so on and so forth, micrometastasis need to be treated.
No, then point is even the normal lymph nodes can have macrometastasis, isn't it?
Yes, that is true. But
so for her, that's how I could understand. Probably lymphadenectomy will tell us, or that's okay.
Right. So, so I think
that's fine.
That's a debatable thing now.
Yeah, I think.
But with counseling the patient, I think we can, counsel her. If we are not going in for lymphadenectomy, these are the risks. And with lymphadenectomy also is not, risk-free. So accordingly, we have to leave the decision to the patient. So now, Dr. Bineet, I'd like to know, is neoadjuvant chemotherapy safe during pregnancy?
Just listening to the discussion, it's a very interesting discussion which has been going on. Data says that you can go ahead with the lymph node sampling, you can go ahead with the lymphadenectomy, you can do it laparoscopically. But I feel with the recent armamentarium of the investigations, especially MRI and everything and ultrasound, you should be reasonably sure that it is 1B2 and not more. That is the mantra. If you are not sure it is 1B2, then probably argument can be given either ways, and at that point of time, it should be an individual patient selection. So if it is that, if you are reasonably sure, then of course, you can go ahead with the neoadjuvant chemotherapy, specifically in this situation. Otherwise, it is not recommended in carcinoma of cervix. So the drugs which are generally given are basically, the sheet anchor is platinums. You can give cisplatin if the patient has a good renal reserve. If there is a little compromise, or you feel that there might be some other comorbid conditions in which cisplatin would cause unnecessary nephrotoxicity, then probably you can give carboplatin instead. Both of them can be switched either ways. Along with that, taxanes can be given. Then the drug of choice here is paclitaxel. So most of the studies which have been there in this context are very small number studies. There are multiple studies, but the number is quite small, 30 patients, 50 patients. And the other meta-analysis which are there, they are probably retrospective. So I feel taxanes and platinums can be combined, and these can be given as a neoadjuvant chemotherapy, about 3 to 4 cycles. And as rightly said, the second trimester is the best time. One should not tinker with the first trimester. And it should be at a 3-weekly interval. And then after that, once the delivery has been done, then probably you can do the surgical staging about 3 to 6 weeks after delivery.
Absolutely.
Can I ask you, how many cycles are safe, Dr. Vineet, in pregnancy to give as a neoadjuvant? Like from 18 weeks, if we don't do lymph node?
Generally around three cycles, 3 or maximum 4 cycles.
6 cycles will be quite a lot.
Actually, it is the timing when you want to start. So 12 weeks of chemotherapy cover, I think, should be okay for a neoadjuvant setting, because fortunately, carcinoma cervix is a very, very chemo-responsive tumor. So those patients who have a response, they start getting a good response after 4 to 6 weeks. That is generally after 2 cycles of treatment. And those were the unfortunate ones who don't get a response even after 3 cycles. They would be clubbed under the primary refractory group. So they don't do better whether you give 2 cycles or 4 cycles or 6 cycles. So I think a median should be about 3 to 4 cycles.
Thank you.
So thank you, Dr. Vineet. So for this, they did a laparoscopic pelvic lymphadenectomy. They gave her 5 cycles of carboplatin paclitaxel. A cesarean section and a radical hysterectomy was planned in 34 weeks, but it was abandoned due to adhesions, and chemoradiation was given. So to summarize, I'd like to say that counseling is integral, as highlighted by all our panelists, that with options of radical surgery or CCRT according to stage of the disease without the preservation of pregnancy, or giving a neoadjuvant chemotherapy until fetal maturity, after confirming that the nodes are negative, either by MRI-guided biopsy or a lymphadenectomy or by extensive imaging. We can go in for a classical cesarean section with radical hysterectomy and lymphadenectomy at 32 to 34 weeks, depending on the nursery facility. Neoadjuvant chemotherapy is safe after 14 weeks with a mandatory 3-week window period between the last cycle and delivery. And neoadjuvant chemo has no deleterious influence on the physical or the cognitive outcome of the baby. So our next...
can I just ask one question? I have not read the literature. You might have read it. I just want to know, do we have any data on the percentage of node positivity in cervical cancer in pregnancy?
Ma'am, there is no separate data I could not find, but this case I had taken from NSGO, which was presented this year. So they did a lab lymphadenectomy, but I could not find any separate data on the percentage of lymph node positive. Generally, if the patient is advanced stage, most of the patients go in for termination of pregnancy in early pregnancy. But there were very less cases who were, studied. There is no as such a data I could not find for evaluation who had a positive lymph node, so many pregnancies evaluated. Maybe I'll go through it again and get back to you.
Yeah, I too will try and do that.
I tried to find that, but generally most of the data are showing that if nodes are negative, then they continued the pregnancy and what was the outcome. It is how they have presented it. But still, I'll look back and get back to you.
Thank you.
So our next case is a 39-year-old patient who came to hysterectomy and salpingo-oophorectomy already done for query PID in a peripheral hospital. The final histopathology showed a 1 by 1.5 centimeter lesion in the cervix, well-differentiated squamous cell carcinoma with positive margins. Uterus, both tubes and ovaries were unremarkable. So Dr. Poonam, I'd like to know what investigations will you order for her to decide on the management? And can we do parametrectomy in this case as completion surgery?
Dr. Urvashi, this is not such an uncommon situation in our country. When we usually get patients referred from periphery, they have done the hysterectomy and patients come to us with this histopathology examination report. First of all, I would like to comment that this hysterectomy was done maybe without a good preoperative workup. Maybe pap smear was not taken, or maybe it was not a good preoperative workup. Now we have the histopathology. It is an invasive disease. and the simple hysterectomy was done. Simple hysterectomy for invasive disease is not a sufficient treatment. We definitely need to boost her treatment with some other form. Now, first to decide how much is the extent of the disease. Extent of the disease, I would like to know radiologically. I would like to examine the patient first, take history taking examination, and then I would like to know the extent of disease either by CT, PET CT, or with MRI, or maybe CT pelvis and abdomen if PET CT is not available. Now, modality, which modality is to be given, that depends on the radiological and histopathological assessment. Histopathological assessment, you have told that she is having positive margins. Now, positive margins, we have to give her postoperative radiotherapy, but after only giving postoperative radiotherapy, the studies show, literature shows that progression-free interval incidence is only 49%. So CCRT is the better option to be given in this case. Now, coming to the whether we can do parametrectomy or vaginectomy for this case, had she been with negative margins, maybe we can decide on that. But in case it's positive margins, so that is not the right modality of treatment in such a case. So I would like to go in for CCRT in this case. Okay. Now
I'd like to know that what is your opinion on HRT for her in the light of histopathology report of carcinoma cervix?
Yeah, this is a very good question. Patient is 39 years and she has undergone hysterectomy with bilateral salpingofracture. So maybe she has been treated for cancer, but her quality of life will be quite disturbed because of her premature surgical menopause. So we have to give her menopausal hormone therapy according to the current guidelines, and guidelines don't differ in case of cervical carcinoma. We can give her monotherapy with estrogens because she has already undergone hysterectomy. So combined therapy can only be is to be given only if we have left the uterus inside. Maybe we have done the surgery for early stage, they have done the colonization. That is a different case, but this case is different. She has undergone hysterectomy for some other reason. So monotherapy with estrogen we have to give to maintain her bone health as well as her general well-being.
Okay, thank you, Dr. Poonam.
I think one very relevant question is now we should first ensure that she is disease-free.
Absolutely.
So, once she goes for CCRT, then of course, she completes the EVRT and brachytherapy. And then after how long you will start the HRT?
Ma'am, once she is declared disease-free, we will start the HRT.
No, like I think she will take 8 weeks of course of radiotherapy. Then we'll wait for her PET CT to be done, whether she has disease or not, after 3 months or 6 months. She should wait at least for 6 months.
Yeah. Ma'am, first priority is her treatment of cancer.
Yeah.
First priority is that. And second is the quality of life. First is survival, then is the quality of life.
Yes.
We have to ensure.
So Dr. Sarupa, as Dr. Poonam pointed out that we have to give radiotherapy in this case. So what is the role of radiotherapy? How do you go ahead in such cases when you?
Yes. So in this cases, Dr. Poonam has said very rightly, the pre-treatment workup is very important because she was not worked up well. After that, since the margins are positive, radiation has to be given, but along with chemotherapy. And we will be including the post-operative bed and the lymph nodal areas. I'm assuming that after the CT scan, there are no lymph nodes present. If there are some lymph nodes present in the CT scan, then we would like to sample that with an FNSC. And because if there is a lymph node which is more than 1 centimeter, we would like to boost it also along with radiation with the SIB technique. So it is CTRT, radiation targeted along with chemotherapy.
Right. Okay. Thank you, Dr. Sarupa. So PET CT we did for this patient, it was normal and CCRT was administered to her. To summarize.
Can I, sorry to interrupt. Suppose the lymph node is more than 2 centimeters, then Dr. Sarupa, you refer her for surgical removal or you boost?
Ma'am, whenever such patients come to us, we first take a surgical opinion. After the whole workup is done, a surgical opinion is first taken. But if the surgery, I'm talking if the surgery is not being done after the surgical opinion, if there are nodes, even if it is not an occult carcinoma, these nodes need to be boosted.
Right.
Because if you see the literature, they say more than 2 centimeter,
Yes.
I think RT will cause many side effects.
Absolutely,
So it's
absolutely.
better to
So
remove
first,
them
yes,
surgically.
I was speaking, that is, I'm speaking after the surgical opinion has been taken.
Yeah, you said
No,
1 centimeter.
yeah,
1 centimeter, of course, will
even
take.
if the node is 2 centimeters, no,
Yeah.
we would still want to first prove it and then try to address it surgically without proving that, because
Yeah.
we are.
Yes.
That I agree. FNAC,
Yes.
of course.
We need to
Yes,
prove
yes,
it.
Yeah,
definitely. So we
that is
quite
should be
clear
there.
on that even if it is 2 centimeters, you still need to prove it before you
Yes.
go into any kind of surgery.
Absolutely.
Right.
So, ma'am, Dr. Rupinder, like first after FNAC, it is proven that it is positive, then you go for removal and then the radiotherapy is given. It is, is
Absolutely.
that how it is?
Yeah, I think that is
the way it should be.
Yeah,
Right.
because you can have, see, we are a country endemic for tuberculosis and so many other inflammatory conditions, right?
Yeah.
She's post-surgical. And
it can be
that's
reactive also. Yeah.
inflammatory, and it can be or reactive or any odd thing. So you don't want to, do an unnecessary surgery for.
Absolutely, absolutely right. So when such a case is referred to us, we first need to assess the extent of the disease by imaging. Parametrectomy, vaginectomy, and lymphadenectomy may be considered in a young patient with a small lesion only with negative margins and negative imaging. If the margins are
If I can just interject over here, see, parametrectomy is a very, very specialized surgery.
Specialized surgery, absolutely, ma'am.
You should attempt it only if you think you have the expertise.
Expertise, absolutely, ma'am.
So
Right.
because the biggest danger in parametrectomy is not that you will leave behind disease. The biggest danger is that you will injure the bladder, and you will injure the bladder in a way that it cannot be repaired. And the patient might actually land up with a ileal fissure. So we have seen people do parametrectomies, and as they are trying to take away just the parametrium, and they try to separate out the bladder, I have seen at least 2 such patients where they have taken away the whole dome of the bladder. In another place where they have injured the trigone of the bladder, which is almost irreparable damage. So you are going to do a parametrectomy, be very, very sure that this is what you are really doing, and be sure that the planes are supple, and be sure that you are not damaging the bladder. So that's just a word of caution.
Absolutely, absolutely, ma'am. In the interest of the patient, we should all know our limitations and the limitations of our institute and tailor it accordingly, or send the patient to a center who has the expertise to do that in case the patient is fit for this kind of specialized surgery. So positive margins or positive imaging, CCRT should be given. But having said that, any treatment you may give post such a case doesn't compensate for lack of adequate surgery, as has been shown by a lot of evidence. So a robust preoperative workup is mandatory and is the key when we are going in for any hysterectomy for a benign case. So coming to the last case, this case is a case of recurrence which was presented in ESCO 2020. I brought up this case just to apprise all the listeners of the recent treatments which is available in the case of recurrence. So she was a 44-year-old para 2 live 2 irregular vaginal bleeding for 6 months. Her last routine gynecological examination was 10 years back. On local examination, there was a 3 by 3.5 centimeter growth on the interior lip of cervix involving the upper vagina. PVR was normal. A biopsy showed a grade 2 squamous cell carcinoma. MRI showed enlarged lymph nodes and deep stromal invasion. CECT showed no distant metastasis but suspicious pelvic lymph nodes. Surgical lymph node staging was done for her, and 8 pelvic lymph nodes were positive. In November 2017, a definitive platinum-based CCRT was given. In 2018, she came back with a recurrence in the left supraclavicular lymph node. It was diagnosed by CT and confirmed by biopsy. So Dr. Vineet, I'd like to know, how will you manage this case, and what are the recent advancements in the field of chemotherapy for recurrent and advanced metastatic cancer?
Well, here again, it can be a combination chemotherapy, or you can add chemotherapy with bevacizumab, which is a VEGF inhibitor. So with chemotherapy, you're going to just kill the cells. With bevacizumab, you're going to kill the blood supply of these cells.
Right.
Now, the question comes, these patients who are given bevacizumab, it is very easy to administer the drug, but then 2 to 5% times this can cause a big problem. Because why I say 2 to 5% times? 95 to 97% times it goes and does its job. It blocks the blood supply to the cancer. So it has a synergistic effect with the combination chemotherapy. It can cause hypertension per se. So those ladies who have hypertension, it can lead to a hypertensive crisis, or it can aggravate the hypertensive situation at that point of time. Secondly, what happens is that these patients can have a bleeding diathesis, can lead to bleeding and bleeding related problems, because this is again working on the blood vessels and the milieu which is there in the stroma. Thirdly, what happens is that suppose you have a tumor and there is a total infiltration of the disease into the through and through, you know. And once you give bevacizumab, the drug is doing its job. It leads to complete destruction of tumor. But once it happens, and if it's a through and through disease, it can lead to fistula formation. So these three things have to be emphasized when you add the bevacizumab with these patients, that is hypertension, bleeding diathesis, and fistula formation. Fortunately, it occurs in about 2 to 5%, but it can have these problems. So once you give chemotherapy versus chemotherapy plus bevacizumab, you have an incremental benefit of about 5 months in the progression-free survival. Having said that, the latest strategy is what you are showing, that is the Pdl1 inhibitors. This is a drug which is known as pembrolizumab. This can be given, you have to do the Pdl1 testing, and that is by the CPS scoring, that is the combined positive score of the tumor cells and the stromal environment around. If it is more than 1, then this drug can be given and it works. And higher the scoring, the logic says that the better is the functioning. So which translates into the fact that if the tumor is more immunogenic, then you give this drug, the maximum incremental effect is there. Sometimes if Pdl1 is not positive, then there is another entity which is known as microsatellite instability. So if you have MSI high, then in these patients also, this can be given as an agnostic marker and can benefit from pembrolizumab. When I say agnostic, I mean that I don't know. I just know that I have a MSI high, irrespective of the organ of origin. If I give, then the drug will work. So apart from the checkpoint blockers, we have other blockers like the Ntrk inhibitors. And these drugs are not available in India, unfortunately. We have pembrolizumab, which is there. Although it has its own financial connotations, because each injection is about 2.5 to 3 lakhs, which you give every 3 weekly. And the irony is that it works. You do a reassessment after, say, about 3 to 4 courses. That's about 9 to 12 weeks. You find there is an improvement. You cause further financial morbidity to the patient. So again, apart from all the other counselings which we generally do and which we have discussed in our forum here, a financial counseling is very mandatory. So if I find that a patient does not have that kind of a financial stability, I forego the discussion. I don't even discuss, because it's going to cause unnecessary mental trauma.
Right.
So you have Ntrk inhibitors, you have VEGF inhibitors, you have Pdl1 inhibitors, and this is a new thought which is coming, adoptive cell transfer. and probably it will be coming to India because outside the cost of each injection is 1.5 crores.
Yeah, right. It's very
One,
expensive.
1.5 crores, C for Calcutta.
Yeah, right.
So it is being tried in Tata Memorial Hospital. So probably once it comes, that would be the actual tailor-made medicine in which you take out the lymphocytes, you synergize them and splice it with the drugs, and again you inject it into the body. So that probably is for the future, another 4 or 5 years from now. So for all practical purposes, CS cervix patients, we give chemotherapy and we give the VEGF inhibitors. We have an incremental benefit. The average survival, if you see in a stage 4 carcinoma cervix, if you go by the literature across the board, is about 9 to 11 months. So that can be hiked up when you give the BEV, that is bevacizumab. You can go up till about 12 to 14 months, and that can be further hiked if you can give the Pdl1 blockers.
Right.
So I think the vista is open now.
Okay, right. Thank you.
If money is an issue, then you can give other single agents like vinorelbine or topotecan or pemetrexed.
Right.
So you can tailor accordingly.
According to the patient.
Yeah.
So this patient received 6 cycles of carbopetyl with bevacizumab, followed by maintenance therapy with bevacizumab. While on maintenance treatment, patient had increase in size of the lymph node 1 year later. That was treated with EBRT. The node regressed, and patient is fit and in follow-up for the past 1.5 years. So to summarize, I'd like to say that regular follow-up is critical for the early diagnosis of recurrence. Paclitaxel and carboplatin along with bevacizumab is considered preferred first-line regimen in the treatment of metastatic or recurrent cervical cancer based on the balance between efficacy and the toxicity profile. And immunotherapeutic strategies and adoptive cell transfer of tumor-infiltrating lymphocytes is the way forward, as told by Dr. Vineet. Maybe 4 to 5 years down the line, we'll have them in India. So
can I ask one question? The Pdl1 receptors, so we would be doing on the original tissue block, or we'll have a fresh sample from the node?
That's a good question. Ideally, it should be done on the fresh block, but if you have a sample which is less than 3 years old, probably you can still do it. There is no problem. More than 3 years old, then data says that if you can procure a fresh block, that would be better. So there's an arbitrary cutoff of 3 years.
Thank you.
Okay. So that was the last case. I'd like to request Dr. Amita to the cases or anything she wants. Amita and Dr. Rupinder would like to say anything for the listeners. Any take-home messages, ma'am?
Yeah, I think whole topic has been covered. It was amalgamation of all types of cases of CA cervix. Now I work in government hospital, lot of load, and see many cases come after hysterectomy. They don't even do and they cut through the tumor. No oncological guidelines. So a lot of awareness has to be created, and we must know what is the routine protocol of post-operative radiotherapy, because they don't complete their radiotherapy in scheduled time, which is 8 weeks, EBRT as well as the brachy. So that goes and goes and goes. That's how we are not getting good survivals. So there are limitations. Government hospitals, brachy is not really available. EBRT is there. Then we have to really send them somewhere else. So CA cervix, we should be detecting it early. Now it's high time. We should not see late cases, but scenario is very different. We are getting advanced cases, neglected cases. So we should now do focus on prevention as well as early detection.
Dr. Rupinder, ma'am, your comments?
Same. I just want to reiterate whatever Dr. Amita had said, and especially since in this post-COVID era, we are also getting a lot of advanced cases, and it's quite sad. Especially, we are seeing many young patients these days, 30-year and 40-year-olds, coming up with almost untreatable disease, and just giving them palliative care rather than anything else. So it will have to be addressed. And of course, like Dr. Amita said, that the paucity of being able to give ICRT and brachytherapy to these patients, Some patients, after a few sittings of EBRT, they start feeling better, and then they just stop, and then they come back with absolutely terrible disease where you cannot do anything at all. A frozen, jammed pelvis, we can't do anything.
So since I have a wonderful panel with me, I'd like to take opinion on a case. As ma'am said, we have young patients. We have a 22-year-old right now with us who is 1B2, married for 2 years, and she wants to preserve her uterus. So ma'am, Dr. Vineet, Dr. Amita, what is your opinion? We can go in for a neoadjuvant followed by a cone for her, or first we should go in for a lymphadenectomy, confirm negative nodes, even if the imaging is normal, and then give her that option. What is your take on such a case?
Cone would not be ideal at all. Even trachelectomy we should think of if
After neoadjuvant, because 1B2 otherwise doesn't qualify for a fertility preserving. She's
even after neoadjuvant, then trachelectomy should be
done.
Should be done. It's a radical and
First,
lot of counseling.
first a lymphadenectomy, ma'am, to confirm negative nodes, or we can just confirm by imaging. What is your take, Dr. Rupinder? We should
No. See, you have to give neoadjuvant therapy and downstage the disease, and then follow it up with the radical trachelectomy as well as a complete bilateral pelvic lymph node clearance. Because, there's no halfways about that.
Right. Okay.
Because the younger the patient, the more aggressive. And also, you should be very, very careful as to what is the histopathology. Be sure it is a squamous cell carcinoma.
Yeah, absolutely, ma'am. Absolutely.
It is not standard of care. Do tell the patient.
Yes, ma'am. Yeah, it's not the standard of care. Right. Absolutely, ma'am. We have to counsel, as you all highlighted. Counseling is the key when we are going a little away from the standard protocol in the as per the desires of the patient. They should know that the survival oncological outcome and the survival is going to be affected. Dr. Sunita, would you like to say anything?
Many patients, they don't listen. They just have this in their mind that, if surgically somehow by any which way you can take away the disease, they will keep insisting on surgery.
Keep insisting, yeah, right.
And then you feel that if you don't do something for them actively, they will not take any treatment, and they'll keep going from pillar to post. And
absolutely, this is what happens.
Downstage resectable disease will become absolutely untreatable disease.
Untreatable disease.
Yeah, and always discuss the case in tumor board. You are safer. Later on, you won't face a medical legal litigation. Because if anything you are doing out
of the guidelines, yeah, right. So definitely. So thank you all the panelists for your pearls of wisdom and the extensive deliberations. I would like to now hand over to Dr. Poonam for the vote of thanks.
Thank you, Dr. Urvashi. It was a very nicely conducted panel. And thank you all the panelists for your very valuable and knowledgeable inputs, especially Dr. Rupinder Sikh ma'am, Amita ma'am, Dr. Sunita ma'am, Dr. Manas sir, and Dr. Vineet, Dr. Swarupa, Dr. Kanika. So everybody was excellent. It was enlightening for us also. Though, Urvashi, we are conducting this, but from your experience, especially for this 22 years old female, which we have recently admitted, it was very enlightening for us. Thank you so much. And thank you, Mr. Shivam, for all your technical support. Thank you, Dr. Sunita ma'am, for giving us the opportunity.
Thank
you all. Thank you all.
I would like all of you to switch on your videos. Please, let's have a picture.
Let's have a picture. Please switch on your videos, all those who are still connected.
Yeah, please.
We also thank you for giving us the opportunity.
Yeah. Well, I thank you for giving the opportunity as well as the opportunity to meet up with everyone.
Yeah. That's important. Yes.
That is a collateral.
Shivam,
I'll request.
Thank you.
Yeah.